Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everyone. My name is Ahmed Al Said. It's my pleasure to chair this session, and I would like to welcome all of you for this SSBMT webinar, which is organized by SSBMT and supported by Janssen. So I'd like to thank both SSBMT and Janssen for organizing and supporting this educational activity. So this activity title is How I Treat Multiple Myeloma with Convenient Therapies. Today, we are lucky to have two eminent worldwide figures in multiple myeloma. We will have two sessions, one about management of newly diagnosed multiple myeloma, and the second one will be about managing relapsed refractory multiple myeloma. So the first session, which is management of newly diagnosed multiple myeloma transplant eligible patients with convenient therapy case studies will be presented by Prof. Saad Osmani. And the second session, management of relapsed refractory multiple myeloma patients with convenient therapies case studies, will be presented by Prof. Harith Nahi. And then we will have 10 minutes for question and answer. So it's my pleasure to introduce the first speaker, who is Prof. Saad Osmani. As all hematologists and myeloma doctors, they know Dr. Saad Osmani, who is a well-known myeloma doctor. Dr. Osmani is a chief of plasma cell disorder program and the director of clinical research in hematological malignancies at Levine Cancer Institute at North Carolina in US. He is an internationally organized clinical and translational researcher focused on plasma cell disorders in general and high-risk multiple myeloma in specific. He's a PI of many well-known phase 3 clinical trials. And Dr. Osmani also is a member of many societies, including ASH, ASCO, IFM, and others. So we would like to welcome Prof. Saad Osmani, who will present again the management of newly diagnosed multiple myeloma transplant eligible patients with convenient therapies. Most welcome, Prof. Saad.
Assalamu alaikum, and thank you so much for the kind introduction. If I can kindly request control so that I can share my slides. All right.
You have it?
I do, and let me see if I can share my slides now. All right, hope you can all see the slides.
Yeah, we can see.
All right, thank you. All right, so it's a pleasure to be in this session, especially with my wonderful colleague, Dr. Nahi. Both of us have worked together on so many different protocols over the years and have known each other. I'm looking forward to our discussion and Q&A towards the end. The topic assigned to me was approach to transplant eligible newly diagnosed myeloma, and I'm going to go over some of the basic principles and some of the new data, as well as how we're approaching treating patients in this setting here in the United States, specifically at my center. These are my disclosures. And I'll start with the goals of myeloma treatment, as these goals have started to evolve over time as we've developed newer treatments for myeloma over the past 15 years. We've gone from treating myeloma quote unquote gently to trying to get patients into very good depth of responses, as that translates into better PFS and eventually survival outcomes as well. So the goals are to reduce the disease burden with induction treatment, reverse disease-related complications, and try to pick treatments that get you to the best depth of response possible. You don't modify treatment right now based on response, but you try to pick the treatments, induction treatment, that give you the best chance of getting into the deepest response. And you try to utilize therapies that don't interfere with stem cell collection for the transplant eligible patients. And then post-transplant, you try to prolong durability of response with consolidation or maintenance, and this delays the disease progression. You try to reduce and minimize and manage the toxicities, and this is where I think we've made a lot of headway with some of the newer treatments, and that helps in balancing quality of life. Obviously, the eventual goal is to extend overall survival, and over the past 2 decades, we've seen the survival of myeloma continue to get better from 2 to 3 years to 5 to 6 years, now to 8 to 10 years, and for low burden disease standard risk patients, even 10 plus years. And obviously, the ultimate goal is long-term disease control and possibly cure. And it gives me pleasure to talk about this, that we have conversations around potential curability of this disease because of what we have in our armamentarium and what's coming down the pike. What we know about long-term survivorship in myeloma is typically these patients tend to have low disease burden and do not have a lot of end organ damage. They tend to have favorable disease biology. They get to good deep responses during that first year of diagnosis, and they're able to receive optimal upfront treatment, including induction, transplant, and maintenance. And anything that does gets in the way of these or has other features, those are the patients who do not have long-term survivorships. And this is where real world data and real world experiences come in play. So what kind of patients do not have long-term survivorship? Those are the patients who have high disease burden, presenting with renal failure, a lot of pet avid disease, and then unfavorable disease biology. So that myeloma is not one disease. So high risk is a heterogeneous subset, but though that kind of disease biology, patients don't do well. If patients have multiple comorbidities, that's also an issue, and it gets in the way of them receiving optimal treatments, as you're modifying treatment based on what happens in the real world for those patients. And then patients do develop second primary malignancies. Myeloma is a disease of older age, and patients can develop other malignancies that influence the outcome as well. Many of us have that one patient who did very well with modest treatment, and that tends to be exception, not the rule. Those kind of patients need to be examined, but you cannot make generalizations based on those kind of exceptional responders. Uh, I stated that myeloma is not one disease. You've probably seen me present this slide, and I always try to refocus the audience to the fact that myeloma is not one disease. And when you're thinking about disease biology and the interaction of malignant plasma cells with the immune and bone marrow microenvironment, that transition to from MGUS to active myeloma is happening at a different pace. And we are seeing these patients at different time points during that journey. This is what makes the disease interesting. Our management strategy for myeloma has been to turn it into a chronic illness, pick treatments that get patients, to those goals of treatment, and then, try to assess them at the time of relapse. Again, picking the right treatments along that time. I think high-risk disease is still a big challenge for us, but there is a concerted effort to try to do clinical trials specifically for high risk. And then, there have been advances in myeloma biology over the past, from the 2000s into the 2010s. And they've led to therapeutic targets specifically for myeloma pathways, but now there are therapies that are looking at immune regulation and modulation, and also influencing the bone marrow microenvironment. So having said that, ISS and revised ISS staging is what we have utilized. I think ISS staging gives a good idea about disease burden and maybe an indirect idea about disease biology, but did not give us a lot of information about disease biology. And that's why the revised ISS staging system was introduced, where certain high-risk features were incorporated. And even the revised ISS staging system is about 6 years old. It only incorporated a few of the high-risk features. And this is where things become challenging. So someone can have a high-risk feature, but if they do not have a beta-2 microglobulin that is 5.5 or higher, they would be in revised ISS stage 2. And many of us, have seen patients who progress very quickly, or not do well with treatments or response to treatments because of because they're characterized as revised as stage 2, but they're behaving like ultra high risk patients. So these staging systems are in use, but I think you have to take this with a grain of salt as you're thinking about what they really mean. Many revised ISS stage 2 patients clinically behave like revised ISS stage 3. Then the other important point I'd like to make is myeloma is not a mono, we call it a monoclonal disease, but the myeloma cells have, in a given patient, there are many multiple clones. And these clones are present at the time of diagnosis. There might be a predominant clone that is captured on that pelvic bone biopsy, but these clones, become active or regress under duress of treatment over time. If you're treating patients with single mechanisms of actions, you may be able to control one or two clones, but there is going to be another clone that emerges at the time of relapse, kind of making the point that, combination chemotherapies are needed for optimal disease control. However, we also have to bear in mind that different clones may emerge at different bone or extramedullary sites, and the only disease biology that we are assessing for patients is the pelvic bone. So, you have to kind of keep that in mind, that, our methods of evaluating disease biology and its ability to predict for outcomes or prognosis, or prognosticate based on that, is still a bit rudimentary, even with the tools that we have in the year 2021. This is the typical paradigm of treatments that we have followed, and patients are assessed for transplant eligibility during the course of their initial or induction therapy. If they're transplant eligible, after they've had 4 or 6 cycles of induction, they go on to receive an autologous stem cell transplant with high dose melphalan as preparative regimen before going on to maintenance treatment. And for the transplant ineligible patients, they continue that initial therapy until the response is plateaued before going to maintenance treatment. And you continue maintenance to relapse, progression, or intolerance. It's important to appreciate the supportive care measures that we need to incorporate in the care of patients for bone health, pain management, infection, etc. Let's go over this case. So we have a 51-year-old patient, good performance status, who was evaluated for worsening fatigue with exertion and pallor, exertion and dyspnea, dyspnea and exertion and pallor. Hemoglobin was found to be 9.2. Their chemistry panel was within normal limits. Beta-2 microglobulin was 4.1, albumin was low, M spike was 1.5 with IgG lambda isotype, and the light chain ratio was abnormal. They did not have any high-risk features on FISH, but had significant plasmacytosis at 66%. And PET-CT did show lytic lesions in the ribs and L3, and they were hypermetabolic areas. They were more than 3. So they were diagnosed with standard risk, ISS and revised ISS stage 2 multiple myeloma. So let's go over some of the data and the treatment approaches. This is the typical approach that we take for patients who have either standard or high-risk disease. So, we have either VRD for induction or DARA VRD for induction. I can tell you at our center, DARA VRD is the preferred choice. For high-risk patients, it's either KRD or DARA VRD, and we can talk about this during the discussion. Once patients go through induction, we mobilize them and proceed with an autologous stem cell transplant. If they're not getting into a stringent CR or better post-transplant, we may consolidate them with a cycle or two of the same induction that was utilized. For standard risk patients, they go on to receive LEN maintenance. For high risk patients, it's PI IMiD-based maintenance. If someone has bulky EMT or primary plasma cell leukemia at the time of diagnosis, we are a bit more aggressive. So for younger patients under the age of 65, the Arkansan in me comes out and we use VD pace as part of induction for those patients. For older patients, we follow the same schema that I showed you in the previous slide. For transplant eligible patients, we follow those patients post-transplant with RBD maintenance until relapse and progression. And in certain instances, we have considered reduced intensity allo for patients who are younger, especially if even the post-auto response is suboptimal. Then for transplant ineligible patients, they continue RVD as part of maintenance. Usually we do drop the dexamethasone. These patients end up being on high risk for CNS involvement. So we do um, uh, check their CSF analysis at the time of diagnosis to see if there is any involvement. So this is like the typical transplant eligible approach that we have. Let's walk over some of the important data that has led to this point. So the SWOG 777 study was a trial that looked at VRD versus RD induction for 8 cycles before RD maintenance. Now, the patient population for this trial was younger, at a median of 64 years of age, but transplant was not part of the treatment strategy. Nevertheless, this trial demonstrated superiority in terms of both PFS as well as overall survival in favor of VRD. Now, at that time, when the paper was presented in 2016 and eventually published in 2017, many of us were already using VRD as part of induction treatment. So this kind of validated our clinical practice. What about carfilzomib, KRD? Most of the trials are phase 2, except for, even the Forte trial is a randomized phase 2 study. We have seen strong data in terms of depth of response for transplant eligible patients, very impressive PFS in phase 2 studies. But perhaps the strongest signal we've seen in each of these trials is for high risk patients. And that's the reason why we utilize KRD preferentially for high-risk patients in my program, barring any insurance issues, to get patients to a good depth of response if we can. The data, VRD data, comes from the Griffin trial that was led by Pete Voorhees from my center, and we enrolled a lot of patients on this randomized phase 2 study. The schema of the standard of care arm was VRD for induction, followed by transplant and then VRD for consolidation. Then daratumumab was added into the schema of induction and consolidation on the experimental arm. And then for maintenance, DR was continued in the experimental arm as maintenance, whereas R was continued in the standard of care arm. The primary endpoint for the trial was stringent CR rate by the end of consolidation. And the idea of this randomized phase 2 study was to look at the feasibility and see if we are improving depth of response post-consolidation for these patients, and laid the groundwork for both the Cepheus and Perseus phase 3 trials that are currently fully enrolled but awaiting results. In the newly diagnosed setting. For the Perseus trial is for transplant eligible patients. Cepheus is for transplant ineligible patients. And the Griffin trial showed superiority of the daratumumab containing arm in terms of the primary endpoint. Stringent CR rates at each step of the way were superior to the RVD arm alone. So that, one of the things that I'd mentioned in my initial slides is getting patients to a good depth of response in that first year of diagnosis is very important. And this is, so addition of daratumumab is able to help us achieve that. And the median follow-up is only about 27 odd months. I think there's another update coming, which will be a 3-year follow-up, I believe, at ASH. But so far, the PFS and OS rates, were similar. This comes with a caveat. I shared with you that the median OS for myeloma is 8 to 10 years. If you're going to see a difference in the OS, you'll have to wait a long period of time. You have to keep that in mind. It's not even going to be visible at 7 or 8 years. And that's my critique of the IFM 2009 study. Then we have the Cassiopeia trial. The initial, this was one of the largest transplant eligible trials that have been done, and was done in a very fast-paced environment. It was kudos to our European colleagues for enrolling this study very quickly and then reporting on the primary endpoint within, I think, 3.5 years or so. The schema that you see is very similar to the Griffin trial up until the consolidation part, except that the induction is with VTD and data VTD. And there's a second randomization to the study where patients who got to a PR or better, there was a second randomization to either receiving data as maintenance treatment every 8 weeks or observation. So the primary endpoint was met for the first randomization in favor of daratumumab VTD in terms of the 18-month PFS. And for the OS, there were some trends emerging, but the data was immature at the time of the original publication. However, there is, with the second randomization data of data versus observation was just reported at ASCO and EHA in June. And these were the data in favor of daratumumab where median PFS was not reached versus observation. Now, this trial has been critiqued because, the standard of care now is for LEN maintenance. What was very interesting to see in this study at the time of the report was the fact that patients who got data as part of induction and consolidation, they don't appear to have the same kind of benefit compared to those patients who just got VDD and then got data as maintenance. So this is a very important observation. Introduction of daratumumab, it appears, at least from the US practice standpoint, if we are using data as part of induction and consolidation, it begs the question whether we can just use data monotherapy. Now, there is a trial in the US called the SWOG 1803 that is looking at maintenance, comparing dara-len or dara-len with lenalidomide. So I think that will be the more relevant study. However, if someone cannot use len as part of their maintenance for whatever reasons, I think dara becomes a reasonable choice, because it is extending PFS in the transplant eligible patients. So, I think from this study standpoint, there was reduced frequency of data maintenance, which significantly improved the post-transplant outcomes in newly diagnosed patients who receive VTD. Longer follow-up is needed for potential PFS and OS benefit. And this updated result from part 1 supported the early use of data containing regimens. And then obviously, Griffin data needs to be updated, Perseus or IGA data, which is also looking at data len as maintenance, but with an MRD endpoint. That will elucidate, more practice informing and practice changing lessons for all of us. So the key takeaways, clinical takeaways are, for induction and consolidation, RVD with or without daratumumab is, very feasible. We have strong data for that. There is strong data for KRD, especially in the context of high-risk patients. We actually just saw at IMW, data with Forte again, especially for high-risk patients who were getting KR maintenance. That was the second randomization. And then, for short-term future, I think add daratumumab to all versus risk or response adapted. Those are some of the trials that are going on. There are going to be molecularly adapted regimens, with fewer cycles that are in development from a clinical trial standpoint. Are for standard risk as maintenance. We are with or without data for high risk is something that we all utilize. And then the SWOG 1803 study that's looking at dara-len versus len as maintenance in an MRD-driven fashion is going to be important. And then, long-term future, I think bispecifics are coming into play, and there are going to be trials kind of utilizing BiTEs. There are also trials, coming from the CARTITUDE program that are thinking of comparing autologous stem cell transplants to CAR T cell therapy. So, with that, I will thank you for being patient with me, listening to what I had to say, and acknowledge my team here at Levine and hand things back to Ahmed. Thank you.
Thank you, Prof. Saad, for this excellent presentation. We'll leave the questions for both talks at the end of the webinar. So it's my pleasure now to introduce Dr. or Professor Harith Nahi. Professor Harith is a senior consultant in the Department of Hematology at Karolinska University Hospital, Stockholm, Sweden. Dr. Harith is a senior lecturer and associate professor in hematology. He is also the chair of the Nordic Myeloma Study Group. And Prof. Harith also is heavily involved in the research focusing on multiple myeloma. So Prof. Harith will speak today about management of relapsed refractory multiple myeloma patients with convenient therapy, and most welcome, Prof. Harith.
شكرا يا أحمد and السلام عليكم للإخوان والأخوات في السعودية. So I'll try to give you an introduction. I mean, talking about relapsed refractory myeloma is not the easiest subject to talk about, but I will try to give you headers or general ideas about how we do in Stockholm. So Saad talked about the first-line treatment, but regardless line of treatment, our aim when we treat myeloma patients is to achieve the best possible response, preferably an MRD negative response that we measure by as you know, by fax and some kind of either magnet camera or PET. To see if there are any lesions that are still active in the body. When tolerated, high-dose treatment is still the standard, and followed by maintenance. What we use is for low-risk patient is the LAN. The high-risk patient we use and proteasome inhibitor, and sometimes we add on daratumumab nowadays. For elderly frail patients, we don't use high-dose treatment, but as you've seen in the slide of Dr. Saad Usmani, there is an age limit about 65 that we can discuss. But in elderly frail patients, we don't use high-dose treatment, but we give a longer treatment. I almost never, in a responding patient, I almost never cut on the treatment. I continue with only LAN without cortisone. Our strategy to give LAN as maintenance is every second day. So we give 25 milligrams every second day as a maintenance. Or in elderly patients, we give above the age of 80. You know, the Swedes, they live very long compared to Middle East people. Over the age of 80, we give 15 milligrams every other day as a maintenance. Some of my slides I brought from the CCO. Please look at this slide. Very interesting slide, very interesting presentation from different experts in every area of oncology. So if you have the time, just log in and look at presentation in myeloma and other hematological oncological subjects. So if I have a slide of, brought from this side, then it is marked with the CCO. This is a wonderful slide. I mean, when I started my career in hematology and myeloma, we had melphalan, and we had prednisolone. And when the patient relapsed, we used melphalan another dose, either every 4th week or every 6th week, trying to adjust the dose. So there was nothing. Nowadays, you can see all these promising drugs, and these slides don't show all drugs. Trying to classify them in groups, then you have the image, including the thalidomide, lenalidomide, pomalidomide, and CELMoDs that are now developing the proteasome inhibitors, as you know, the bortezomib, carfilzomib, and the ICSA. Chemotherapies, adriamycin and doxorubicin, I don't use them, not today, and haven't used them earlier either. I don't think that they have a place. Other chemotherapies, cyclophosphamide is widely used in Sweden and in Europe. Bendamustine, never use it the last 5-6 years. Melphalan, we use it only as a high-dose treatment, as to say intravenous, not tablet form. My first choice of the steroids would be the DEXA, and other novel mechanism or drugs as the panobinstat, virinostat, selinexor, melphalan, not widely used, I would say, in Europe. The MABs, as you know, the elotuzumab, daratumumab, ISA, and Blenrep are widely used, and the upcoming therapies with the CAR-T and T-cells engager will be promising, mainly in relapse refractory patients, as the studies are in this population, but I hope they will be soon in first line. So this is an old slide just to demonstrate why I'm using the regimes that I'm using in first line. And as you see, the most promising combination, as you probably heard from Professor Osmani, is the combination of an IMiD proteasome inhibitor and a cortisone. That is the RVD with the highest response rate. When we change initial treatment at our site, we always do retrospective study to make sure that we are getting a benefit to the patients. So the slide to the left is comparing induction of Cy plus Dex to Cy plus Dex to bortezomib. When you see the difference in survival. The next one is when you change to CyBorD, we compare it. We compared the CyBorD to the next treatment, which is the VRD, and you see the difference in survival there also. Our treatment today is bortezomib, Cy, Dex, and daratumumab, because Len is not reimbursed in first line in combinations. So I would, if I have a free hand, so I would do exactly as Professor Osmani, as to say, I would use VRD and DARA in frontline. Regarding high-dose treatment, as you see earlier, the age of 65, we don't really respect this age. I mean, if you have a well-fit patient, then we aim for high-dose treatment anyway. These are our results, and the dots, the black dots, are representing patients undergoing high-dose treatment in first line when they are between the age of 65 to 75. So the survival of these patients is almost as the survival of younger patients going through high-dose treatment. So I would say high-dose treatment up to the age of 75. Then the use of modern drugs. This is, you know, in Sweden they have a lot of registry. They started by the church registry, and nowadays since the 50s they have cancer registries. So it's very easy to take out data and do some statistics. These are they have 6 different regions in Sweden. The red one is my center, Stockholm, and you see the survival difference. It is almost 10 to 20% higher survival in Stockholm compared to all other sites in the country. And why is that? We try to look on the reason for that. And you can see in the figure to the right that the centers using modern treatment have the better survival. And if you see which region are using the modern treatment, the blue one have the highest use of modern treatment. As to say, our center utilize the more modern treatment and getting the better survival. This is an old study from 2013 comparing patients in first line to the left, getting either IMiD or proteasome inhibitor or both of them in first line. This is the line in the red in the middle. The blue one is on chemotherapy and the black one is the MASH normal population. The figure to the right is the same patient treated with proteasome inhibitors or IMiD, both at now it's both in first and second line. And as you see, the gap between these patients and normal population is decreasing. So the more use of modern therapy, the better. Now it's a more modern picture for all soft cancer registry. The slide to the left for all the patients only look at the blue line. This is my center. It is a comparison region-wise. But if you only look at the blue line, the figure to the left showing patients between 65 and 75. These are elderly patients in the era between 2008 and 2014. And to the right, if you look at the blue line again, the same patient population, the same center and the same doctor, and you see the survival is not reaching 60% at least 6 years follow-up. And that's probably because the introduction of the antibodies, mostly the daratumumab, to the treatment. So how to treat relapse refractory myeloma patients? I really believe in combination. Some say that the patients are elderly, they are weak, they are relapsed myeloma, but you can always reduce the dose. You can increase the interval and use combination. I mean, giving one drug with a probability of response of 30 to 40%, you cannot face a cancer patient and saying, I will treat you if you have a 1/3 chance of responding to treatment. So my strategy is always to use 3 drugs and in sometimes even 4 drugs. These are the possible for 4 drugs combination in myeloma patients. So what's relapse refractory myeloma? As you probably see, the IMWG criteria for relapse, I mean, the increase in protein, both in serum and light chain, that's very known to you. The difference between involved light chain should be more than 100 milligram per liter. The new criteria that SAD probably is one of the authors in this article. I don't really know if there is a validation if you increase in 10% of the plasma cells in the bone marrow. I mean, I myself might take bone marrow aspirate from the same patient in different occasions before starting treatment, getting 15 and 35. This is 20% increase in plasma cells. Even new lesions. I mean, within time, without progress, if you take X-ray on the patient, the myeloma lesion might increase with time without being a progress. So look at these criteria with carefully before starting treatment. But a relapse refractory myeloma patient is a patient fulfilling the criteria of the IMWG. Patients are progressing on treatment or within 60 days when you end up the treatment, or if they are primary refractory. And only relapse myeloma is a patient fulfilling the IMWG criteria for progress, but don't fulfill the relapse refractory criteria. Looking at different combinations in relapse refractory setting, there are several studies. These are some studies comparing a new drug compared to Lendex. DARA, RD in Pollux, KRD in Aspire, ELO RD in Eloquent, and ICSA in RD in Tourmaline. What's your first choice for the first relapse? Well, you should look at the first-line treatment, but looking at these data with the lowest hazard ratio, I would choose the DARA RD. And you see the response rate from that. If you have used the LEN in frontline, then you can probably switch the LEN to POM or to carfilzomib and combine with daratumumab dex. That's what I do. If you have used LEN in frontline or DARA in frontline, I would probably choose carfilzomib POM dex. Other trials comparing to VD, the Castor comparing the DVD against VD, the Andover comparing carfilzomib VD, the panobinostat VD, and the POM VD. And once again, the lowest hazard ratio is with the use of daratumumab. So we are talking about convenient treatment. One should talk about tablets and not injections. But I mean, the COVID era in Europe learned us a lot. So that even sub-Q injections are feasible at home. So my patients don't come to the clinic for the DARA or the VD. We learn their first-rate relatives how to give sub-Q injections, and we supply them with the drugs, as to say, the patient's son or daughter or wife come to the clinic, bring the needles and the injections home, giving it to the patient and returning them once weekly. So we prepare a package for the first-rate relevant relatives to the patient and try to, even if it's not a tablet, try to learn them how to give the sub-Q injection at home. When talking about relapse treatment, today you have to see or to talk about the T-cells engager. This is a table that I present at the IMW comparing single agent treatments. As you see, the thalidomide, bortezomib, lenalidomide, POM, carfilzomib, whatever, the response rate is between 20 to 30, probably 40 in some cases. Even the daratumumab that we talk so much about as a single agent, this study was done by both me and Professor Osmani. The response rate in the European cohort was 34%. In the what I remember in the American cohort, it was 29. So the combination of both became 31% response rate. Looking at the T-cells engager, the teclistamab, telequitamab, the response rate in heavily treated patients, this is about 70%. So I need all just to mention the T-cells engager, which are the upcoming drugs. In Europe and in Sweden, we have access to them as a compassionate use program from Janssen. So my conclusion is that 3 or even 4 drugs combination is feasible in relapsed refractory myeloma. The response rate is 60 to 93%. Compared when I started treating myeloma, when giving methylprednisolone, the response rate 30, 40, in best case scenario 50% in first line. The response rate are much better when using modern drugs and drug combination. Side effects are manageable. I mean, every hematologist using these drugs are used to manage side effects also. T-cells engager are very, very promising, and hopefully that you guys will have access to them in very near future. Thank you for listening, and thank for my collaborator. Thank you.
Okay, thank you, Professor Harris, for this excellent presentation. And is Prof. Saad with us? Okay, so we go now for question. I'd like to ask all the attendees to submit their question. We will start with a question from Dr. Osmani, from Dr. Benjamin, Osman Benjamin, about you. In Saudi Arabia, we do see younger patients, myeloma, in their 20s even. And sometimes they present with the high-risk features like high-risk cytogenetics or extramedullary disease. So we know these patients, maybe they are, because of the age, they are underrepresented in clinical trials, so people, they don't know how to deal with them. And one of the options always we keep discussing in our leukemia board or BMT board, should we consider allogenic transplant for these patients or not? So what do you think, Dr. Atmani, and also Prof. Harith?
So my opinion there is, if you do not have access to clinical trials, if a high-risk young patient is not getting into a VGPR or better after, having good induction transplant with or without consolidation, I think it's a reasonable discussion to have, and it's something that you can offer. If you have a young patient with high-risk disease who's already relapsed 1 or 2 times, that's where, I don't see a major benefit of allogenic stem cell transplant, because we have not seen, long-term outcome, good long-term outcomes. You end up having a patient who has sequelae of having had an allogenic stem cell transplant and the myeloma also coming back. So it becomes, a management nightmare from that perspective. I would welcome, thoughts from Dr. Nahi, on this topic as well.
So allogenic, we use it in all plasma cells leukemia frontline. In myeloma, as you saw, my aim is an MRD negative status. We try our best to reach that, and we don't give allogenic in frontline, but in early relapse, as to say within 24 months. So in first relapse, we consider always allogenic transplantation. Most of these patients will relapse within 6 to 8 months. We get them down to MRD negative status and do an allogenic transplantation, and not being satisfied with that. If the patient don't have an GVHD, then we always give a combination maintenance treatment. And our combination is daratumumab carfilzomib or daratumumab POM. In about 2-3 years, even the patient in CR, we keep on maintaining the effect of allogenic transplantation.
Thank you. So if we have a young and we consider allotransplant, would you go for RIC or myeloablative, and what conditioning would you suggest or recommend? Dr. Saad? You are?
I could not hear you. Can you kindly repeat the question, please?
If we have a young patient and high risk, and we decide to go for allogenic, so what conditioning, and would you use RIC or you go for myeloablative for these young? What's your suggestion?
So if it's a young patient, go for myeloablative, preparative regimen, and every institution is different. So, at my institution, the chair of our program is Dr. Ed Copeland or Professor Copeland, who is a big proponent for BuSci. But we've used Flu-Cy TBI as well, in our patients as well. We haven't utilized BuMel as much as MD Anderson, but that would be another option.
So I agree with Saad, but if the patient is not getting to CR, we always do a high dose treatment before doing allogenic. And probably in that case, we will give a RIC instead of a myeloablative treatment.
No, good point, Hirath. I agree with that. Yeah, so disease burden
Okay.
also matters in your decision making. I agree.
Okay. So for CAR T cell, Professor, is there any trial or a concept of using CAR T cell as a consolidation? Is it there, or we should use it only in relapse setting?
Yeah, so there's actually a concept in BMT CTN that I'm trying to move forward, and hopefully it will go through for high risk patients. But the idea is to use post-auto consolidation with CAR T cell therapy, BCMA CAR T cell therapy for high risk patients. And the high risk definition includes patients who have circulating plasma cells and EMD and a lot of high risk features that many times get excluded. I'm hoping that we can get a good protocol up and running by next summer here in the United States. I don't think outside of clinical trials, there is enough evidence to do something of that nature. But we have what we are calling the BMT CTN 2021 protocol. It's kind of in development based off of the consensus we had at our State of Science meeting this year.
Good. So I see a question from Dr. Fahd Sharif. How effective daratumumab in extramedullary disease?
It's a hit and a miss, and I would like to again, Dr. Nahi is another experienced physician with use of daratumumab. I have seen some patients benefiting quite well from daratumumab, especially in earlier relapse setting. But what we've seen across the clinical trials is the addition of daratumumab may help, but the signal is not very clear. So I think that it's a good drug. I think it is beneficial for most patients. The signal, however, remains unclear for high-risk patients. There is no harm of adding daratumumab to control high-risk disease, but the clinical trial signal is not very strong.
So I would agree with the last sentence that Saad said. You can use daratumumab, but always in combination in high risk and extramedullary disease. So you should combine and not use single drug.
Do we have daratumumab refractoriness like IMiDs and Velcade refractoriness? Do we have this definition now? Or?
Well, depends on what you mean. Some of the patients never respond to the daratumumab, and what's the mechanism behind that? We don't really know. Probably the proteins and the cell membrane that daratumumab is attacking is not getting the connection, or not placed in the right place in this protein to destroy the cells, are not getting an immunological reaction to be effective. But there are patients that will never ever respond to daratumumab.
No, yeah, what I mean, like we switch from lenalidomide to pomalidomide, Velcade to Garfield Zombie. When do we consider switch from one monoclonal antibodies to another monoclonal antibody?
I would say if you had an initial response on daratumumab and you have treated the patient and the following relapse with other treatment, and you can most probably try it again. But patient not responding to daratumumab, then you cannot say that they will respond later on. But if you have an initial long response and you treat with something else and the patient relapse again, then you can probably, if you don't have anything else to offer your patient, you can use daratumumab in combination, and in sometimes it will work.
Yeah, I would agree with Dr. Nahi there. So the idea would be if someone has had a response to dara in the past, you can combine dara with a new drug that the patient has not seen to get the best benefit. But if they did not respond, then the likelihood of getting any benefit from dara would be fairly low.
Okay, Dr. Harris, there is one question from Dr. Mazen al-Maliki. Is there any specific approach for transplant ineligible relapse refractory myeloma with a previous exposure to lenalidomide, Velcade, cyclophosphamide, who present with severe renal impairment approaching dialysis? So, Dr. Harris?
I would say my first choice would be darapom with the combination of cortisone.
And so for before the Candid trial data came out, darapom dex was our go-to regimen. Now we also use daracarfilzomib dexamethasone for those len refractory patients. You have to pick and choose patients based on their comorbidities for carfilzomib. But that would be the other potential choice. I agree with Hera. DPD is a very effective regimen, and we use quite a bit of DKD in our patient population too.
One tough question: how you treat CNS myeloma?
So CNS myeloma, you need to separate two identities. Either you have a plasmacytoma, which is near the bone, and that is not that dangerous, or you have a plasmacytoma without any connection to the brain, and that is very dangerous. How we treat the combination of several drugs together, and the survival is at max 18 to 24 months, but no connection to the bone, plasmacytoma in the brain is very rare. In my whole career, I've probably seen 5 patients. So it's very important to remember, if it is a plasmacytoma in connection to the bone, it happened to be in the bone, as it could happen to be in the leg or the thigh or the spinal, the spines. So it's not that dangerous, in my opinion. But a free plasmacytoma in the brain is very dangerous. We did some observation on, you need to know if the drug passed the blood-brain barrier or not, and how effective they pass the blood-brain barrier. The one that we know that very effectively pass the blood-brain barrier is the thalidomide and the bendamustine. I don't know if the modern drugs are studied for such mechanism of action or not.
Yeah, so I echo what Dr. Nahi said. I think you have to be very clear when you say CNS myeloma, that you either have a CSF analysis that's showing malignant plasma cells or leptomeningeal enhancement, or it's very rare to see parenchymal disease in the CNS, but that's real CNS myeloma, and that is bad. When I was in Arkansas, unfortunately, we put together a series of close to 40 patients who had CNS myeloma in the Arkansas experience, and one of our younger physicians published that data maybe 7-8 years ago, but the outcome was pretty poor for those patients. So you have to, when you say CNS myeloma, it's not the plasmacytoma that's adjacent to the dura. Yeah. It's very different. It's true CNS myeloma, and that's poor. We do not have many drugs that are effective. Selinexor has good CNS penetration, or I think the CSF to plasma ratio is something like 0.5 for selinexor, as well as for pomalidomide. And then merizumab was another proteasome inhibitor that had good activity, but it never was developed by Takeda, if I recall, or was it Celgene? Either way, I don't think we have many drugs that get into the CNS, and it's a very difficult, challenging kind of disease.
One last quick question.
There are no CNS myeloma experts in the world.
One last quick question, Prof. Saad. For high-risk myeloma who cannot get Velcade for peripheral neuropathy, what you will give, lenalidomide or ixazomib or DARA, or what other for maintenance?
I would actually give lenalidomide with carfilzomib. So the Forte trial data that's been shared, it's showing a very strong signal. The same PI-IMiD maintenance strategy that we saw working for high-risk patients in total therapy, then in the SWOG 1211 trial, then in the Emory experience that was published last year, and now with Forte, is that you combine a PI and IMiD. I would pick either bortezomib if patients can't tolerate bortezomib, then it's now carfilzomib, because Professor Francesca Gay, who's presented the Forte trial, she just one of her colleagues presented very strong data for KR as maintenance for high-risk patients specifically. I was very impressed with that data. I would welcome thoughts from Dr. Nahi about it.
Okay, with that, times is up now. I would like to thank our speakers for their excellent presentation, our attendees for their time, our organizers and SSBMT for organizing this activity. And hopefully we'll see you soon in the next activity, which will be again about myeloma on next Saturday. So with that, hopefully we'll see you next week. Thank you for all.
شكرا أخي مع السلامة.
سلام. شكرا.
Assalam.
Thank you.